This video touches on the topic of suicide. You might be coming to this video as a researcher or suicidologist who engages in this subject matter in your work, as a survivor of suicide or suicide loss who has been personally impacted by this subject, or as a policymaker looking to translate research into policy. However you're showing up today, the topic of suicide can evoke a deep pain and emotion. Before we begin, I'd like to start with a few grounding reminders, borrowed from Dr. Jeffrey Anslus. You may want to consider checking in with yourself to decide how and when to best watch this video. Maybe you want to watch it with other people. Maybe you want to watch it in the morning and not late at night. We invite you to bring a good heart, a good mind, and a lot of compassion for all as you watch, including yourself. Feel free to take a moment now to pause, reconnect with yourself, and reflect on how you plan on engaging with the content today. There are resources available to you should you want to talk to someone. Depending on where you are in the world, those resources may look different. In the description of this video, we've provided some places to start, with options to get help for yourself and help with supporting someone else.
Um, thank, thank you, Lucas, and thanks everybody for your time. I'll get these fired up. Can everyone see my screen? Awesome, thank you. So thank you again for your time today. Andrew Rogers and I are going to be talking about pre-specification of statistical analysis plans, as well as quantitative approaches for suicide care pathway research. Andrew and I are both part of the methods core for SCRC, and we're also part of the quantitative sub-team where we're available to help folks with statistical and quantitative related questions that might come up and needs that you have for your project. The talk that we're doing today is especially geared for the research teams doing projects through SCRC so that we can provide some guidance and advocacy around developing your data analytic plans. So specifically today, we're going to cover these three topics. I'll be kicking us off by talking about pre-specification of statistical analysis plans. And I'm also going to preview a optional SCRC data analytic plan template that we're offering to folks and encouraging them to use. And then Andrew is going to take the mic and talk about how to use your conceptual models to develop and make the most of your statistical analytic plan, and then how to leverage the most from your pilot studies, given that pilot studies come with an interesting set of advantages, but also disadvantages when it comes to doing statistical analyses. And so that can often be a challenging thing to think about that he's going to help us through. We're going to save questions for the end as well. So we'll try to block off at least 10 minutes for any questions that folks have. So starting with pre-specification of statistical analysis plans. When we talk about statistical analysis plan pre-specification, what we mean is having a detailed and documented strategy for analyzing your study data. And usually this is something that's created before the study begins or before you start your data analyses. And there are multiple purposes for doing this that we encourage people why we encourage people to do them, including that it increases the credibility of your findings. It can help address concerns around p-hacking or overanalyzing your data. It can also help with reducing bias in the way that you analyze and report your study outcomes. It's also helpful for teams because it helps ensure that the data analytic approach that we're going to follow is really targeted and structured and focused. And finally, all of these things together really help promote research integrity. So we'll talk a little bit more about these as we go on. In broad brushstrokes, what we're talking about in terms of elements that would go into a data analytic plan. Usually it's the following 7 things, including the specific research questions or objectives for your project, the primary and secondary outcomes and any hypotheses that you may have related to those outcomes, the statistical methods that you'll be using, how you'll handle any missing data if it should come up in your study, the analytic sample, meaning who's going to be included in which of the analyses and what data will be included, any potential planned subgroup analyses. So if you're focusing on specific subgroups within your larger sample, outlining those ahead of time. And then any covariates that may need to be included in your models. We have a template, as I mentioned earlier, that helps guide researchers to think through and structure all of these parts of the data analytic plan that I'll preview in a few minutes. Sometimes when we talk about data analysis plan pre-specification, our brains go to these really extreme examples of dishonest research, and that's fair. We think about these terms like p-hacking or overanalyzing your data or data mining, which in turn lead to these kind of like systematic concerns about the research enterprise in general, like the replicability crisis, nefarious researchers, public mistrust in research. Um, Somebody like this who, if their data doesn't reveal the insights that they want, they're going to slice, dice, and drill that data until they get some sort of results that they can publish on. And this is fair, this happens, but of course, most or all of us in this room, this would not apply to. But I would also argue that there are a lot less extreme examples where data analysis plan pre-specification can really help us through some of the challenges that will come up as we do our research, even when we're doing research with high integrity and honesty. So, for example, when we're doing studies that involve any kind of real world data used for research, we often have to use our own human judgment to decide how we're going to clean up that data and prep it for analysis. And this is especially true when we do a study in a real world setting, like in a primary care clinic, where conditions are constantly changing. And maybe our data sources, like EHR data that we use for outcomes, were not really designed for research. They were designed for clinical care and billing. So we have a lot of work to do to clean that data up and make meaningful use of it for research. So this is a place where human judgment gets involved in the process, and our pre-specification plan can really help guide us in a structured way to approach these issues in a thoughtful manner. In addition, it's also not often obvious which covariates we might need to control for in our statistical models. And so again, we have to use human judgment to figure that out. Outcome distributions for our primary and secondary outcome measures really impact the kind of models that we can use to work with our data. But paradoxically, we don't really know what those outcome distributions are going to be until the study is over. So, for example, if I was doing a study where suicide attempt or suicidal ideation was my outcome, I might observe that outcome a lot less frequently than I anticipated or powered on in my analysis, which might impact the best statistical approaches that I could take. We also have this thing that this interdisciplinary center, and in different fields, there are different methods that commonly get used and preferred. So in psychology, there are methods that don't really get used very often in medicine, and in user-centered design, the same thing. So there may be different audiences or stakeholder groups that we're trying to connect our research with more, and that might also influence which methods we want to use because there are norms within our fields. Some statistical methods can be pretty complicated and they can be difficult to implement in practice or difficult to describe to our stakeholders in a succinct and clear way. So if we're trying to communicate our research findings to primary care providers, community members, family members, loved ones, patients, then that further guides or impacts what statistical approaches we might decide to use, and we might find that we need to modify or tweak things to make them more understandable to our stakeholders. And then we have this quote that the analyses that we do for table 4 might depend on the results that we get from table 3, meaning along the way we found some really interesting finding and we want to probe that more and understand that finding a little bit better. So that guides us into doing some unplanned analyses that we might not have pre-specified. So I'm just pointing out that all of these are different scenarios where even honest investigators really have to make a thoughtful decision about what to do with their statistical analytic approach. And there's not necessarily a black and white, right or wrong answer for what to do in these scenarios. So it can become really complicated. And this is why I think that developing and working with our pre-specification plans can really help us navigate these tricky situations that inherently come up in every kind of study. So here's the question: does pre-specifying our statistical analytic plan save us from all of these things that I just talked about? So in an ideal world, if we pre-specified our analytic approach, that would mean that before ever seeing the data or running analyses, we would pre-specify every variable that we're going to look at, including the exact calculations for that variable, any transformations, any cleaning procedures, and so on, as well as every detail of the statistical analytic plan for modeling those measures. And that would include all the details with enough level of precision that we could just directly translate this plan into statistical software syntax so that we could run all of our analyses. And we would outline which procedures we would use to test whether our modeling assumptions are met. So for example, if we're doing a linear regression model, there are certain assumptions of linear regression that we might want to check on. And then which results from our statistical model we would focus in on to understand if we reject or retain our study hypotheses. And we would pre-specify every possible alternative analytic plan that we might need to make based on the things that could come up that we don't anticipate. So this could include every possible decision rule for taking an alternative approach to measuring some of our variables or to conducting our analyses. So you might imagine that this could result in like this huge decision tree of complexity where we're thinking ahead about every single possible scenario that we could encounter with every measure or every analytic approach that we're going to take, which could quickly become very overwhelming and unfeasible to do. And of course, when we're doing our research, time, money, and energy are not infinite, so that could be impossible potentially for us to navigate ahead of time a priori. On top of that, most of our studies were testing multiple hypotheses and multiple outcomes, which further makes this complicated. Curveballs are common in clinical research, especially when we do research in real world settings, or when we use pragmatic outcomes that were not originally measured for research, like EHR data. And unplanned analyses can really help us have a deeper understanding of what's happening in our study that we might want to also explore, which we couldn't model or which we couldn't necessarily plan for a priori. So instead of thinking of pre-specification as a one-step process, something that we do completely and have done before our study is ever conducted, I'd like us to instead think about it as this evolving or developmental process that really gets formulated across the lifespan of a study. So starting at the very beginning of our study, when we're proposing a grant, we might have this embryo of an idea of what our statistical analytic plan is going to look like, but it's vague, it's undetailed, it lacks a lot of precision. And then over the life course of the study, we start to develop and grow and make more and more precise our analytic plan. And we're constantly updating it and evolving it until we're at the end of our study and we have this really well-developed, specific, articulate statistical analytic plan. So this is kind of like the central argument that I'm going to make today is that we should think of this pre-specification plan not as a single step, but really as a continuous feedback loop, something that we're continually updating and evolving as we do our studies as needed. So for example, to put this into more practical terms as we think about research grants, we're starting with a more general statistical analytic plan. When we do our grant application, there might just be one paragraph that says we're going to do a survival analysis, and the outcome variable will be time to first hospitalization. Fairly vague. And as the life of the grant goes on, this analytic plan gets more and more detailed, more and more fleshed out. And we have a lot of opportunities to do this along the way. As we're planning our study, we can the pieces of the study are coming together. We can update the analytic plan as that goes along and as our measures and procedures become more and more crisp. And then as we launch our study and really kind of finalize the procedures. And then as we're monitoring the data quality as it comes in and we're understanding some of the nuances that are found about our measures or our procedures. And then as we're cleaning and processing the data to prep it for analysis, we're again uncovering more insights about maybe tweaks that we might need to make. And then as we're doing preliminary data analyses, not looking at the study outcomes necessarily or testing any hypotheses, but just doing descriptive analyses to understand what data that we have. And then as we do our primary data analyses, and even as we do some post hoc data analyses that might be informed by the interesting insights that we get from our primary analyses. So this is a process of going from more general to more detailed. I'd like to show the analytic plan templates that template that we've created for SCRC. This is a modified version of a template that I have been using for many years. I use it for all of my projects. I also pretty much require every mentee that I work with to use an analytic plan like this for keeping their projects really structured and giving us a common common document and a living document to continue to work with over the lifespan of the project. We highly encourage SCRC investigators to use this for their projects. It's not required, but it's encouraged. And we especially encourage folks to use it if you're going to be getting any quantitative support from the methods core. Andrew and I and others are happy to provide that kind of support, but having some sort of written analytic plan just really helps us work with you in the most productive and effective ways possible. That's why we're encouraging it. If you have your own template, though, or some other document that you're using to track your analytic plan, that's fine. And we want investigators, like I mentioned, to treat this as a living and evolving document that can be modified throughout your study. So we will send these slides out and we'll make it known where to find these resources, but I'm just going to open it up and give you a brief preview of it. Can folks, well, it's loading right now, but it's on our SharePoint drive. Can folks see this Word document? Fantastic.
Yes. Yeah.
Let me zoom in a second. This computer is going very slow for some reason. So this is our analytic plan template. It's a Word document, and we made it a Word document on purpose so you can slice and dice it any way that you need to. You can really make this yours. You can add sections, delete sections, write in the margins, use comments, whatever you want. This is really a tool for you to use for your project in any way that you find helpful. We have included spaces to write some basic information about your project, like who's involved and what the title is. Some information about who's going to be doing your statistical analytic work and any known questions or concerns that you may want consultation from the methods course quantitative subteam in. So you, as these things come to light, you might use this section to note those down so that when you meet with us, we can have those questions right at the top. Then below, we have some sections where you would provide a general context or background of your study, copying the specific aims and any hypotheses that you have. Often these are sections that you would not need to write original text for. You could literally copy and paste from a grant application what the background is and what the aims and hypotheses are. So we're not trying to duplicate work. We're trying to just have a living place for these things to live as because they might be revised over time slightly. Here's a section where you can articulate what the inclusion and exclusion criteria are. Again, you might copy and paste this from a grant, but as the life of the study goes on, you might find that there are additional inclusion and exclusion criteria that change. And then really the heart of this analytic plan document comes in this section here, where we've left a space for investigators to write down each of the variables that they're going to be looking at in their study. This includes the dependent variables or outcome measures. You would write the name of that variable, like suicidal ideation, for example, a definition of that variable, which might be score on the CSSRS 1 to 7. And then the type of variable that this is, like an ordinal scale or a binary measure or a categorical variable. And as the life of the study goes on, you might find that you're needing to add additional detail just to make it clear how these measures should be modeled and analyzed when it comes time to do your analyses. There's a section here for independent or predictor variables, as well as any descriptive measures. These are measures that are not predictors or outcomes necessarily, but are important for describing who was in your study and what happened to them that you might want to also characterize. Any potential confounder variables, and then any potential other measures of interest that don't fit into any of the tables above. And then we have this section below for where you can write in paragraph form how you're going to approach your statistical analysis. And this would include how you're going to approach any descriptive analyses. So how are we going to describe who was in the study and what happened to them? Your main analyses, meaning how are we going to test our hypotheses? What statistical procedures are we going to use? How are we going to test the assumptions of the statistical procedures that we're using, etc. Any additional analyses that you might need to run, like sensitivity tests, and then any power analyses, if applicable. Again, we might have these in a grant application, but they might need to change as the study goes on. So for example, I'd like to pull up a template that I have used in one of my studies just to illustrate the life of these. So you can see that here's where I've defined all of my measures that I'm using for a study. And then as the study goes on, I'm realizing there are additional measures that we did not originally specify that we needed to include, but were important to include for one reason. So this is a living document where we're tracking changes as we go along, making notes to ourselves of the things that we still need to figure out. Um, our primary outcome for this study was linkage to outpatient treatment after a person was discharged from the hospital. And we found that there are actually three potential data sources that we might need to consider when we're doing this. Self-report by the patient, the UWEHR, and then Medicaid claims data. Each of these has its own complexities. Some people do not complete the 30-day follow-up. Some people are not on Medicaid in the study. So we have all of these decision rules about how to combine these into a single yes or no linked or no linked outcome measure. So this is the place where we're documenting all of those things. We did not have this level of detail or precision in the grant application, but it's really important as we move closer and closer to getting these outcome measures that we really have a fine-grained understanding of these. So this is kind of why we're saying like this living document, a place to really keep track of this information as it comes to light. Um, so this is the link to the analytic plan template that we just looked at. Molly has provided a really nice example of a completed template from the source study, which we're also making available for folks to look at as one completed example related to suicide care research. The example from Molly's study is, of course, a living document. And so just understand that it might change as well. We encourage folks to treat these as a living document. So as new information comes to light, modify it as needed. Also, you can treat it as a historical record of your team's decisions. So which analyses were truly planned in advance and which ones were actually exploratory, and when and why did we change any measures or analytic approaches? We can document that with this. I also like to treat this as a communication tool. So it's something that every member of our team can turn to when needed. Our data manager, our data analyst, a statistician, a consultant, a PI, a co-investigator, it's kind of the go-to place for us, at least in my experience of where we might find information about the measures and analyses that we're going to work with. And then to also treat it as a trail map. So once you're ready for analysis, this thing, as it's more and more fleshed out, can really be the guide that your analyst follows when it's time to run analyses. And when it's time to write up your methods and results sections, it can also really directly translate into those sections and make that process a lot easier. And then also as a tool for double checking your study design. So the more we flesh out our data analytic plan in advance, the more we might find potential disconnects between any aims, hypotheses, measures, and statistical approaches. So if we can catch these in advance before our study is over, all the better. We can make those changes. Ideally, we encourage folks to start the analytic plan pre-specification as early as possible and update it as you need to, tracking when changes occur, including how they relate to key milestones in your study. Like, was this change made before or after we started recruitment, or before or after we analyzed the data separately by treatment groups, and so on. FDA clinical trials provide one example of like benchmarks for when to pre-specify. The FDA says that primary and secondary outcomes need to be specified before the trial even begins, but covariate selection, model specifications, and the ways that you handle missing data can be ironed out after the data has been examined, provided you have not separated the data between treatment groups. So you haven't compared or looked at the outcomes specifically within the treatment group compared to the control group. But this is just for FDA trials, which is not necessarily reflective of here. It's just one example of guidance that's out there on when to pre-specify. I want to point out that pre-registration is not the same thing as pre-specification. So pre-registration means uploading your study information to something like clinicaltrials.gov. This is something that's required for all NIH-funded clinical trials. They say that this happens no less than 21 days after enrollment of the first participant. And the primary goals of this are to promote transparency, integrity, public awareness of clinical research, and compliance with federal requirements. There are other registries that you can upload studies to, and you might find these especially helpful for non-clinical trials like OSF, Open Science Framework. These can be a little bit more flexible in terms of the templates that they provide. They are not just designed for clinical trials. And there's multiple different pre-registration sources that you can look at though in your own time. So takeaways and asks. It's never too early to write down your data analytic plan and then to treat it as a trail map, a communication tool, and a living document. We've provided that analytic plan template and we encourage you to use it or another template of your own. And we are available for consulting around quantitative methodology. So please do not hesitate to reach out and ask. You can ask as early as you want. Um, and having that written analytic plan really helps if you're going to seek consultation. So we look forward to working with you. I am going to pass the mic over to Andrew, who's going to talk next about using the most of your conceptual models to guide your statistical analytic approaches.
Awesome. Thank you, Kevin. All right, let me share my screen here. Let's see if this is going to work. I think we're seeing the wrong one, so let me just swap this here. All right, is everyone seeing the correct screen here? Okay. So thanks for that, Kevin. So I'm going to start by talking about a conceptual model. And this is going to be a nice segue from what Kevin was talking about, because this is really going to be a visual representation of the study that can guide then what's going to go into your pre-specification plan. And again, a living document, but really to get you to start thinking about how we can map the analytic plan onto the study aims. Then I'm going to talk about pilot studies, which is really where a lot of the studies in the center right now are, and to really figure out ways to leverage the most from the pilot studies and where some of the maybe the shortcomings are. So I'm going to start by talking about what is a conceptual model. So I want you to think about a conceptual model is really this guide for how you think about statistical analyses and how variables are hypothesized to be related to each other in your study, right? So this is just an example, in an example conceptual model, not related to suicide research, really just talks about how, our outcome on the far right side is bladder health and lower urinary tract symptoms. And you can see here, starting from the left side, these sort of hypothesized directions and relationships between variables, right? So some sort of from left to right, and you can see some that sort of hypothesize other sort of pathways and relationships here. So this is one example of how things might relate to each other. These arrows, as you can see, sort of hypothesize these direct relationships. You don't see sort of longer paths from, let's say, workplace ergonomics on the left to all the way bladder health on the right. So this is really sort of thinking, okay, we've got this hypothesized pathway and these direct relationships. You also can use conceptual models to model things that could be potentially more complex, right? So we could see that there are these direct relationships that exist here in this conceptual model, the sort of same outcome on the right, this bladder health, but on the left, we're starting with adverse childhood experiences. We're also sort of hypothesizing, as you see here, these arrows that point to the middles of the lines rather than the boxes, talk about things like moderation, right? So if there are variables that you anticipate to modulate how variables are related to each other, you might sort of graph them this way of how different variables are related. Again, right, this is before you're doing your statistical analysis. So this is really sort of based in theory and conceptual grounding. And, it just is a way for you to guide, okay, well then what's going to go into my statistical analysis plan? So if I'm hypothesizing a moderation, that can sort of be indicated here on a conceptual model. It can then be translated into your pre-specification plan. So conceptual models are important because they can help us define our research question. They can identify the main variables and visualize the relationships that you want to model. Identify also these influencing variables, confounds, the mediators or moderators, and control variables. So really everything that Kevin showed on the pre-specification plan can be visually represented in conceptual model. And, before you're starting to think about, well, what is the analysis that I need to answer this question about how X and Y are related? You might want to visualize first, well, how do I hypothesize they're related? And then we can come up with, well, what is the analytic approach? We have this methods core aim to create conceptual models for all the studies that are in SCRC, and I will show you that in a moment, and Lucas will put the link in the chat momentarily. But we are, thinking that this can be a really helpful tool for the projects that are going on here. So in thinking about the SCRC specific conceptual models, right? This can also help you identify not just what variables are in your study and how you hypothesize them to be related, but it also can help you identify what your study cannot answer. And I think that this really leverages where things are right now in the center, where we have a lot of pilot studies that are not, fully powered clinical trials to assess efficacy and effectiveness, right? So if we're thinking about that is your goal of, let's say, one of the R34s, right? Like we might think that that's actually maybe not answerable by the study that you have right now. It can be sort of part of a future study plan and things like that. But this really can help you start to think about, well, what are the limitations also of where I am in the study that I have. So I'm going to show a few different conceptual models right now that relate to SCRC. So we have this, you probably have all seen this conceptual model that was in the grant application, the suicide care pathway, really of how, sort of this, from beginning to end, left to right, how we want to think about things in the center, right? This is a conceptual model. Of course, the studies that we have break this down even further, but this is a way to think about, research and research questions. When we think more about the specific study, so this is, and Lucas, if you could pop the Visio link in the chat, that would be great, because it's a little bit blurry. But the methods core has started to, and we've gotten pretty far, to take the studies that exist and map them onto our conceptual model, right? To start to highlight some of these relationships that the studies are hypothesizing exist, right? So you see here this, the colored boxes relate to a specific study. So the purple one and the top we'll focus on in just a moment is focused on SORS, right? But this is an intervention study, right? So there are going to be, as hypothesized in the study, specific treatment components and components of the intervention that are examined. And these are each thought to impact outcomes. So we'll skip to the far right, reduce suicidal events, suicidal thoughts, through mechanisms and mediators, right? So the hypothesis here is that, for instance, therapeutic assessment increases therapeutic alliance, which is then related to outcomes. But we also see that, for instance, driver-focused skill building, the third one down in the purple box, is hypothesized to impact outcomes through increased self-efficacy and not through, for instance, increased linkage to care, right? So this really sort of gets at these hypothesized relationships. And then when we're guiding our analytic choices, of course, we're gonna model the relationships and or mediations or moderations that exist here. And this really provides that framework to say, wait, what did we hypothesize here? This is really a direct pathway to say, oh, actually, self-efficacy is the thing that we want to look at between driver-focused skill building and outcomes, right? If we find something else, great, but that's more of sort of a post hoc exploratory analysis that we can put in that end of the pre-specification plan or not based on the data analysis. But we really want this to be grounded in, what do I hypothesize ahead of time? What are these relationships? Great, okay, now we can develop a statistical analysis plan of the exact models that you're going to run based on these models. Okay. There are, as you see here, some of these things that are blank, right? Process outcomes. We also have some things that are covering two short-term outcomes, long-term outcomes, or that sit right in the middle of those two things. This is still a work in progress, and we really want this to be a document that is helpful to all people. And I think, as particularly more R03s come in and, investigators that exist are getting new studies, like we'll want to use this as a framework that will, we can send this out in a framework for people to say, okay, where is my study sitting here? What am I missing, right? Is there something, and you might want to use this as you're writing your grant, like, oh, actually, I really want to be thinking about, a process outcome or a mediator or moderator that I didn't think about. How can I fill that in? There's some other boxes that I just didn't fit on the screen that you'll see on the Visio about demographic characteristics. This is a good place for you to put, how do we anticipate the hypothesized demographic characteristics to fit into our model, right? Or not, but just for you to all be thinking about that as you craft your pre-specification plan or your next grant application. So conceptual models can provide clarity to the research question, including mechanisms. They can help with this pre-specification analysis plan before beginning your study. And as Kevin mentioned, we can provide consultation on the pre-specification plan, but we we can also provide consultation on your conceptual model if you are sort of wondering, how does this map onto an analytic plan, or am I missing something? Do I need to be thinking about how these relationships go together? I'm happy to provide that consultation, and I think that it could be a helpful place to start if you are struggling to put together your pre-specification plan. I know that my first question will be, okay, let's pull up your conceptual model. And if that feels like that's not fully fleshed out, I think that's a really good place to start. And then moving on to your pre-specification plan. So from there, we really wanted to think about, okay, well, with the exception really of SCRS, which is the R01 in the center, most of the studies that exist are sort of in the pilot study nature. And of course, we can have these really great conceptual models, but we really want to be thinking about, okay, well, if most of the studies are pilot studies, like what are the things that we can answer, and where are the limitations of what we can answer right now that can then be used to guide future research? And so you might have a conceptual model that guides your whole research program, and your current research study might answer only a portion of that conceptual model, which is okay. But to just keep in mind, like, okay, I might be answering these boxes, but these 3 boxes to the right, that's going to be for a future study, but might not actually be answerable by the pilot studies. So leveraging the most from your pilot study. Okay, so the goals generally from a pilot study are feasibility and acceptability, right? To use this conceptual model to guide intermediary measures, so distal and proximal mechanism, self-report versus objectively measured constructs, right? Like to really understand, what is the research question that you have feasible? Are the methods feasible? These kinds of things, right? So can you recruit your target population? Can you randomize a target population? Can you keep people in the study? Will participants do what they're asked to do? Can the treatment be delivered if it's a treatment study? Are the assessments too burdensome? Are the treatment conditions acceptable? Are the treatment conditions credible, right? So these are things that are really related to treatment-based research, right? These are questions that can be answered from pilot data. I'm also going to show things that might be not necessarily more interesting, but interesting mechanistically. This is actually some data, and Kate and Keeney have seen this data. This is some data from a pilot study of caring context that we did. And the purpose of me showing this data is to show some other ways that you can leverage pilot data that can be helpful and publishable, but are not yet sort of determining, is this intervention efficacious or effective? So I'm going to orient you to this large graph. And this is an ecological momentary assessment study of caring context. This is not a randomized clinical trial. This is sort of an open trial pilot study. Everyone in the study receives caring context. What you'll see here on this graph, on the black line on the bottom, is desire to die, as from left assessment 0 or baseline to right 60 days later. The gray shading indicates the month of the assessment. So month 1 to month 3, they received a week of EMA 3 times a day in each month. So we see the suicide outcomes on the bottom. Then we are seeing, in this case, we hypothesize a number of mechanisms: perceived burdensomeness, sort of belongingness, general mattering, social responsibility, and personal responsibility. Those are the colored lines above the black, right? This is not telling us anything about statistical inference. This is not telling us anything about p-values, but really this is showing us, okay, well, do my variables of interest, my mechanisms of interest, seem to map onto my outcome? Anecdotally, looking at this, it seems the blue and the green lines actually map quite nicely onto our outcomes. Those are perceived burdensomeness and thwarted belongingness, sort of upticking, in those variables with an uptick in desire to die. The questions remain also around, well, how do the top 3 colors map onto your outcomes? This is not a statistical inference, to repeat that, right? But we can sort of visually examine, are these mechanisms plausible for our outcomes? We could probably say yes, and also inconclusive as the top. But a way for us to leverage our pilot data to say more than, well, is this feasible? What percentage did they complete? We can start to also look beyond that and say, well, okay, this is feasible in ways, and our mechanisms also might be feasible as they relate to outcomes. That's one way for us to use pilot data. Another way for us to use pilot data is to look at, for instance, a within subject correlation of a mechanism, right? So this is not to say, so this is looking on the x-axis, we'll see desire to die. This is within one, well, it's within person, the lines you're seeing, desire to die, and then perceived burdensomeness on the y-axis. All right, each of the colored lines is one person, and it looks at, okay, well, over the course of the study, which is this study, right, over the course of the study, how do these things relate to each other? Does desire to die relate to perceived burdensomeness? Okay, well, we're seeing sort of a moderate positive correlation. So as perceived burdensomeness goes up, desire to die goes up, right? This is not to say, oh, well, perceived burdensomeness is the reason why people's desire to die increases. But this is just to sort of give more sort of feasibility to, okay, well, maybe this mechanism is a plausible mechanism. For some of the other things that we looked at, I didn't show the graphs here, but we are seeing more flat lines. So that might sort of give us indication that, well, maybe some of the other things aren't as plausible or feasible of mechanisms for our outcomes. Right? Another way to leverage pilot data. This is, again, not saying, oh, well, this is the thing that we are going to action on, right? Or what caring context actions on, but this is sort of a preliminary investigation of, oh, okay, these things might be related. Okay. So again, right, so aspects that can be examined with a pilot study, and again, thinking about then where your analytic plan goes, right, feasibility, screening, randomization, retention, assessment procedures, as well as, you know, how are variables related. What I am now going to show you is the things I think that as I was diving into this initially of ways to not use pilot data that actually a lot of times quite surprised me, because I think as you know, you hear in the field, I think a lot of the things that I was reading, I'm like, oh, wow, I thought you could use a pilot study for that. So I just want to sort of bring this up here. So pilot studies cannot be used to assess the safety and tolerability of a treatment. They can provide a preliminary test of your research hypothesis, as I was showing there, but not answer the same questions that you would answer in a fully powered RCT. So in the pilot study I was showing you, we might be able to look at, okay, so in people who receive caring contacts, does it look like perceived burdensomeness is related to suicide, to desire to die? We might be able to say, well, maybe, but we're not going to say, does caring contacts reduce suicidal ideation, right? Because we don't know that, right? That would have to be done in a randomized controlled trial, which is currently ongoing. So, you know, I want you to think about that. And as you know, we routinely see people looking at preliminary efficacy, right? But we don't want to be looking at preliminary efficacy. We can look at a preliminary test of the research hypothesis, but we're not sort of doing necessarily a strong, fully powered comparison of our interventions. We also don't want to use pilot studies to estimate the effect size for power calculations of a larger scale study. We can use things like minimally clinically important difference. We can use epidemiological studies to understand sort of like prevalence rates of outcomes or something like that, but we don't want to use our effect size that we get in a pilot study to estimate power for a larger scale study. So here's one of the challenges, and why that's the case is because you can see here, if we have a small sample size, we're going to have quite a large confidence interval. And so we might see here, if you look at this third line down here, that we're seeing that sort of middle rectangle is at about, you know, let's say 0.25. But you see this confidence interval goes from below 0 to above 0.5 or 50, right? And so we actually don't know where the real effect is, and that real effect may not exist. Larger samples, we're going to have actually quite a tight confidence interval. With the smaller sample, we're going to get an effect size, and it actually might be quite unreliable and unstable and imprecise. And so this is sort of not the way to use a pilot study most effectively. So here's this graph that I really like to look at, the pitfalls of estimating preliminary efficacy in a pilot study. So if you look here on the left, there's sort of an example, a pilot study that shows a very weak effect size, and that your power analysis shows that you need over 500 people per intervention arm in your fully powered study, which may not actually be true because the imprecision of the effect size estimate. So you may conclude that the intervention doesn't work. You may never pursue an efficacy study if you think that if you're doing a 3-arm randomized controlled trial that you need 1,500 people. It might be too expensive or would involve an unnecessary, as I mentioned, large number of participants. On the flip side, you might say, wow, well, we have a really strong effect size and you only need 12 people per arm of a clinical trial, right? So you're also not going to run a fully powered 3-arm clinical trial with 36 people, right? And so your subsequent clinical trial will be underpowered to detect a clinically meaningful effect. Of course, there are many, many more considerations as to the number of people that are included in the clinical trial and all these decisions around power and things like that. But it can be sort of a slippery slope if you are using pilot studies to generate power calculations for future studies. So again, right, clinically important effect size can be a really good marker, or if there's, if your, outcome is prevalence rates that exist sort of on an epidemiological scale can really be national prevalence rates can be sort of good ways to determine power. Of course, there's this, as I mentioned, caveat that there are budget limitations that can impact feasibility and sample size, right? Which I think is something that we all grapple with, right? If your statistician comes back with a sample size that you need, even, realistically, that you need 1,500 people to be fully powered, like that might not be feasible. And so really trying to think about using your team to work through the pros and cons of that. So, the considerations here are, to think about what a pilot study can and can't offer, tailor your research questions accordingly, using that conceptual model to say, okay, well, we really hypothesize that this is the mechanism of action of treatment. We may not be able to fully test that, right? And so thinking about, well, what can we look at with our pilot studies and what do we need a larger study for? They are a necessary aspect of research. So don't use this, talk to say, well, I'm just going to jump to an RCT. First of all, that probably won't be funded. But second of all, they are really a necessary aspect of research because they really can help and understand, well, if I do this thing on a larger scale, is it going to work? And leverage pilot studies for your next grant applications, or really think about that pilot study is not the end. The pilot study really is the beginning, in a way to think about, okay, well, I can answer these questions, and then here's what's next. Use the methods core again for consultation. I said to Kevin yesterday that is the ask on all of our slides, but it's true. Utilize us to really help you think about, well, I have this study and I was thinking about trying to test this. Is that feasible with the data that I have? Given some suggested readings here, I won't go through them now, but I'm looking here. We've got about 9 minutes, so I'm going to stop here and we're going to open it up for questions.
Ian, you've got your hand up.
Yeah, hi guys. Kevin and Andrew, so well done. I, spent so much time working with folks building their research careers and research skills working on this stuff, and that was just so well put. I learned a lot about how to communicate these concepts to people in a really straightforward way. So thank you for that. One of the things that, I think, it's consistent with everything that you said. So I'm not saying this as like a contrarian. I'm agreeing with you. I'm just kind of brainstorming about it. There, especially with the pilot stuff, we come up with these ideas. And I remember working with Kate on, like the original proposals, like what were we going to put in? What were the plausible conceptual models, how might these work? And, that pathway of like the tadpole all the way through, it really ties together with that conceptual model, just like you said, Andrew. I also wanted to call out the opportunities that we have to really take seriously, and I think can be enhanced with our community partnership, with our, using a user-centered approach to this, to really think through, like, what are the possible ways that these different variables, these different factors that you have in your intervention, and then the conceptual model, intervention, and analytic plan, like being willing to really take advantage of using those users, to gather. I mean, it's such a fun, interesting, intellectual process to be doing that part of the science, right? To really think through like what the heck is actually going on here and set it up in a way that you can, and the pilots probably won't be, I mean, it's something as simple as, self-efficacy, let's say. Well, simple or not, but like somebody, looking to see whether somebody's actually I don't know, some other variable too, but someone is actually doing some activity like showing up or using the tool or whatever. Like if they're not even doing what you thought they would do, but they're still having, some good outcomes. Like, there's a lot of ways to think about in a pilot, like, oh, well, maybe I guess that can't be right because, they're not even showing up to do that task or whatever it might be. So I think we want to be really take advantage of the pilots to, really think like, oh yeah, the conceptual model doesn't make sense. Let's make some modifications. And that's definitely happening with us, as we build our tool with Ampere, thinking about it not really being a detection tool, but which is what our grant says. And, we're really having to modify this a lot, early on, because it's really much more about monitoring and the detection has to happen first. And, so they're just like a lot of really cool things that we should be just engaged with at this level all the way through. And I love that tadpole idea. Like we're just iteratively really think about it and not just like you set this up and wait to the end of the study and then you run your analyses. Like this should be a real active, growing part and fun part of the process.
Thank you for that comment. Yeah, that makes a lot of sense. I think, one of the things you're saying is to really involve your partners, your community-based partners to co-develop these things together. I'll say that in other projects where I've involved community partners, like they will often help you see the big picture, and not get so focused. Like, sometimes as researchers, we put our microscope on and really focus on this one thing. This is what the specific aim is, and I got to focus on that when they might have a really salient question like, are providers happy with this intervention or something like that? Or, like what are they saying when they talk to patients about this? Something really that might seem really simple, but that we just didn't think to look at.
Right.
I really like that suggestion.
I mean, it makes it that pilot part like this creative process. Like, I really dislike projects where, we like write the grant, do the work like we're just like executives or something, and then run the analysis and yeah, it worked or it didn't. Like this should be it's an active, creative experience all the way through.
Yeah, thank you for that.
I think it's a real dialectic because I think there have been this pendulum swing because of people doing some problematic things and undercutting people's belief in the research. They've now polarized so far the other way that we are all losing our minds from administrative paperwork to be sure every single thing is pre-specified and the good clinical practice or whatever issue that has been adopted. For me as a long-term social science researcher, it's like getting handcuffs put on that I suddenly have to do things I developed my own way over 20 years to assure the ethical, and pre-specified activities are now being all defined by these detailed manuals. So I really do think we're at a phase of research right now that has kind of polarized a lot the other way. So the fact that we're doing this and having this conversation and deciding on our tadpole model, which I agree with, is really helpful, uh, Kevin, um, and being clear what we can and can't conclude as a center, I think is important because whenever people, this is sort of now I've been around a long time. Whenever people change these things, it's as if whatever you were doing is like a highly unethical way of doing anything.
Mm.
And suddenly, like, you're totally out of line and blah, 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 just because somebody invented a different way of doing things. And I think different ways will happen again, and different, NIMH will suddenly decide we don't care about, I don't know, please God, NDA, but, maybe RMR or whatever. And suddenly all the rules will change. And I think it's wonderful that we have a plan as a center, and a way of, walking people through just how we're doing this in a way that I think is finding a synthesis between just not bothering to pre-specify because we're in the pragmatic world versus, what we're getting dragged into by essentially medical research, uh, that has its own history and can specify things in ways that I'm not sure suicide research can, and health services research.
Yeah, especially in the real world context of, yeah.
I mean, there's such a, I think about my experience with psychologists, just to, talk about a really different world and tradition, than one that I came from. Although I was initially trained in anthropology, or in a similar kind of way, cognitive anthropology, which is like 1950s, 1960s kind of concept, which, over simplified things, right? And that we like it, and then it's great for as a getting started with things, but then there can be like just a commitment to these very specific things and these very limited experiments, which as to use your term, Kate, the health services, like, sure, there could be one little piece that can really be specified, but then the whole point, in a lot of the implementation work and these other areas of research that require engagement and iteration and development, user-centered design stuff. I mean, that's the antithesis of thinking that we are gods and we know ahead where we're going to end up exactly, right? So I just think that it is important, of course, to not cherry pick your results and then to like say like, oh, I'm so brilliant and see what the results are. And that is, completely undermines the whole point of statistical analysis and things and the principles underlying those. So yes, absolutely, that is needs to be pre-specified. But you might end up with not having any data related to something that you thought you had to have because it's just not possible to have that data. And then, to say that, okay, well, this was a failed trial, we can't, have any results other than to say we couldn't get the data, doesn't make sense either.
Yeah, thanks for that, Ian. I see we're over time. I'm not trying to hold everybody up too much. Lucas, do you want to take it from here?
Yeah, I don't have much to say except we're at time. Thank you both for a really wonderful presentation.
Thank you all for being here.
Thank you for watching this seminar from the University of Washington Suicide Care Research Center. Please take a moment to complete the anonymous evaluation to share your feedback. If you would like to receive a certificate of completion, be sure to also complete the attestation. Links to both surveys are available in the description of this video. Your input is much appreciated.